División de Gastroenterología y Hepatología de Arizona. Ha sido presidente de la División y director médico de la Clínica de Enfermedad Inflamatoria Intestinal y es actualmente presidente del Colegio Americano de Gastroenterología. Su área de interés es el intestino delgado, la enfermedad inflamatoria intestinal y los métodos de diagnóstico para tener un diagnóstico preciso en enfermedades de intestino delgado. Doctor Leighton, muchas gracias por estar aquí con nosotros y vamos a disfrutar su charla.
Muchas gracias and welcome everyone. I want to thank Dr. Blancas and Trujillo. A special thank you also to Dr. Valdivinos and Dr. Gomez for inviting me. I've been to Mexico before, but not Merida, and it's a beautiful city. I'm very excited because it's the first time I'm giving a lecture in a guayabera. So hopefully it won't hinder me at all. So I'm going to talk about tips for a safe colonoscopy. And we know that complete colonoscopy is so important so that we can see right colon lesions. And the idea is intubation rates of over 90% for all colonoscopies, 95% for screening. And in addition, recent randomized trials showed that if you compare colonoscopy screening to no screening, it found colorectal cancer incidence and mortality reductions of 31% and 50%. Not only that, if you have an incomplete colonoscopy, only 30% underwent a complete exam 1 year later. And so this study suggests that if you really want to get a complete colonoscopy, if you can, you should do it the next day, and that's what we try to do at Mayo. The other reason colonoscopy is important is the detection of dysplastic lesions. And we really have to be committed to an adenoma detection rate of 30% in men, 20% in women, and we're thinking that the ideal ADR is 50%. For sessile serrated lesions, we don't know, but we think it should be greater than or equal to 6%. At the same time, though, we don't want to overuse screening and surveillance colonoscopy in low-risk populations. The other thing that's important is detecting polyps, and so it's critical to inspect as much colonic surface as possible with vigorous flushing and looking behind folds. It's important to examine the right colon, and I always do it at least twice. And then maintaining distension in the left colon can be challenging in the left lateral decubitus position, and so sometimes you have to rotate, use carbon dioxide, or examine underwater. And then you want to document a withdrawal time of 8 to 9 minutes, but really not only just that, but improving inspection technique. So in 2024, performing a high-quality, safe, and cost-effective colonoscopy requires using the proper colonoscope, optimal bowel prep, successful cecal intubation, approach to understanding the approach to difficult or incomplete colonoscopy, and then, of course, polyp detection. In terms of colonoscopes, we prefer to use high-definition scopes, and then adult versus peds is a preference. But for adult scopes, the advantage is that once past the sigmoid, there is less looping and need for abdominal pressure, and it's the instrument of choice in redundant colons. The pediatric colonoscope advantage is if you really want to intubate the terminal ileum, known severe sigmoid diverticular disease, or any, but for severely narrowed sigmoids, you may want to use the slim or ultra-thin slope. And then the variable stiffness can also be beneficial. The next thing is the optimal bowel prep, and they should be split, or at least same day. And the second half of the regimen should begin 3 to 5 hours before the procedure. Low volume prep should be the default choice, and the bowel prep should be measured after cleansing using the Boston Bowel Prep Scale, and hopefully adequate preps should be seen in about 90% of patients. In terms of the goal of getting to the cecum, safety, of course, is the first goal, so we don't perforate, but the second goal is to get to a cecal intubation rate of greater than 95%, with loop reduction and wise use of pressure and position changes. You want to avoid pushing against fixed resistance, and really the hallmark of skilled insertion is loop reduction. You want to minimize the risk of bowel trauma, which usually occurs in patients with diseased and narrowed sigmoids or poor preps in the right colon. And then be aware of splenic injury, especially when the tip of the colonoscope is proximal to the flexure and a loop forms, and you want to gently reduce. About loops, I always train my fellows to say if a patient is complaining of pain, it's because of a loop. So they occur frequently, we know that. And you usually reduce by feel, and then after reducing the loops, then the scope should be advanced with the torque used to reduce the loop. Then straightening should always be tried after each turn, and you want to make sure that there's one-to-one transmission. Failure to withdraw sufficiently really is the most common error in redundant colons, and over-insufflation can also be a problem. There are ancillary maneuvers, though, that we can do for a successful colonoscopy. Position changes are important. We start in the left lateral, but then can move to the supine position or the right lateral position, depending upon where the scope is. And then abdominal compression is also very important. And you use suprapubic pressure when the scope's inserted to 20 to 30 centimeters. Left lower quadrant pressure as the scope is progressing towards the splenic flexure. Transverse colon loops can be countered by upward pressure across the mid or low abdomen, and ascending colon loops can be counted by pressure on the right lateral abdomen or upward pressure under the cecum. You don't want to apply it for more than 30 to 60 seconds if you're going to use it. Water filling, these are the most common roles. If you're going to do an unsedated and lightly sedated colonoscopy, it's good to use water filling. Also for an angulated sigmoid, and I'll show you that, and also for a redundant colon. It's good to know about hernias too. For inguinal hernias, you can usually manually reduce them and then follow by re-advancing the instrument. Transverse colons can be a little bit more complicated and often require surgical repair to the colonoscopy. And then you just want to avoid rectal perforation if you're going to retroflex in the small rectums. That's not usually very common. After you've used that expert technique, sometimes it's still difficult. And the reasons that we have incomplete colonoscopy, you can see, I won't go through each one, but there are patient factors, there are technical factors, and then there's the expertise of the endoscopist. And so I will focus mainly on the technical factors. And one of the big things is an anatomically difficult colon. So you can have an angulated or narrowed sigmoid, and that's common in young, slender women, previous pelvic surgery. It really requires patience and exquisite control of the shaft, and I'll show you that. And then once passed, you try to straighten the scope as much as possible. Redundant colons, the hepatic flexure is most common, but you see it in tall men and obese patients. And then you have to be proactive using torque steering, right-left controls, and some people prefer the two-hand technique. But overall, for a difficult colon, you want to anticipate that altered sigmoid anatomy, master the left colon, change solutions quickly, change instruments in a difficult sigmoid, and then be willing to quit at some point if it's not working. For the angulated sigmoid, and I borrowed this from Doug Rex, you want to optimize the tip steering with two hands. And this shows you a little bit of how you can do that because you really need that tight control to get around those angulated sigmoid colons. And that works really well, but you have to be very patient. The other thing you have to do, and I try to teach my fellows that, is you have to realize what's the problem. Is it loops or is it an angulated sigmoid? So when you know for loops, you want to, again, do things to minimize that, and so the adult standard scope, water immersion, or even overtubes are helpful. And then sometimes you have to push through the loop and then reduce after you pass the next turn if the patient is able to tolerate that. And then you can use a combination of variable stiffness scopes, abdominal pressure, or position changes. For the sigmoid colon, as I discussed, you may need to use a skinnier scope, at least a pediatric scope, but maybe an ultra-thin scope. Sometimes we'll use an upper endoscope or a push endoscope, and then you can also use water immersion. The ABCs of abdominal pressure, you want to give support, and you really have to communicate with your clinician where to put it. And then after you've passed the turn, take the pressure off and take the stiffness out of the scope, and then reduce the loop. And it's good to document that in the report. There are other options for a difficult colon that I wanted to review. Carbon dioxide, water exchange, narrow diameter scopes, mechanical enhancements, and balloon overtube assisted. And so carbon dioxide, as opposed to oxygen, is rapidly absorbed through the intestinal mucosa. And studies suggest that it can prevent prolonged colonic distension and discomfort. And a meta-analysis showed a significant reduction in abdominal pain, but no difference in cecal intubation rates. Nevertheless, we use it entirely. And then there's water-assisted colonoscopy, and where you fill the colon with water, the air lengthens the colon, as you can see here, and sharpens the angulations and flexures. When you put in the water, as you can see there, the sigmoid segment straightens, and it reduces the risk of loop formation and barotrauma. And this is really helpful in terms of training, I think, the GI fellows. This looked at the feasibility of an unsedated salvage colonoscopy by water exchange. It was a randomized trial, and you can see that the water exchange significantly increased the cecal intubation rate, and also was associated with lower maximum pain scores, and technical difficulty was also significant lower. So I think water exchange is a great way to do it. You can also use newer diameter scopes, and they're useful because of smaller caliber, shorter deflecting tip, and tighter radius of curvature. And it can facilitate passage of angulated and or narrowed segments as well as fixed segments. And the pediatric colonoscope, which I use the most, may be good for difficult sigmoid colons with or without guide wire exchange, but sometimes you have to go to an upper endoscope, which is more flexible. The challenge there is sometimes it's short and you can't get to the cecum. Ultra-thin scopes without a stiffener are also very useful. So you can use these short-turning radius colonoscopes for fixed or angulated colons, and the slim colonoscope with this short turning radius and greater tip deflection allows easy maneuverability across these angulated sigmoids. And this retrospective study did show that they were able to complete colonoscopy in 37 patients, and also detected adenomas in the right colon. You can, of course, use ultra-thin scopes also for stenotic colorectal cancers. So those are another option. The other is just simple mechanical enhancement, whether you use a balloon or you use one of these devices that you put on the tip. The principles are similar to balloon colonoscopy. It's helpful in redundant colons. It's not helpful in fixed loops or sharply angulated sigmoids. And so you can consider using with a slim scope. There's also overtube assisted colonoscopy, and this is an adjunctive technology that allows for diagnostic and therapeutic intervention in patients with very redundant colons, or if they have sharp angulations or severe diverticular disease. And the overtube helps to straighten the endoscope and the colon upon loop formation and fixed angulations. It can also increase cecal intubation rates, helps with patient tolerance, and decreases the need for sedation. And this is really the neatest one I've seen, called the novel rigidizing overtube for colonoscope stabilization and loop prevention. And it's an endoscopic overtube that was approved in 2019. It's 85 centimeters long. It's a single use and accommodates a pediatric scope. And what happens is the overtube is advanced to the desired location in the colon, and then you reduce as much as possible. And then there's a vacuum device that's applied and causes the overtube to become 15 times stiffer. And in a small study, it was useful for incomplete colonoscopy, both to get further into the colon and also for overall stability. And then there's balloon overtube assisted colonoscopy. And the way the balloon works, you can see here on the right there, you insert the scope as you normally would do. And again, it's much like those mechanical devices, but you can blow up the balloons, advance then the overtube up to the scope balloon, and this is using a double balloon scope. And then once you've done that, then you can use the balloons and continue to straighten out the colon. And it works very nicely in redundant colons. And we offer patients who often have an incomplete colonoscopy, we will send them for a double balloon colonoscope, because you can see how it also straightens out the splenic and hepatic flexures and makes it easier to get around. And in 667 patients previously who failed a standard colonoscopy due to excessive looping, you can see that, that overall the success rate was significant for cecal intubation rates of 97%, with no difference between single or double balloon, and there were no increased complications. And so, that is a great way to use it. And single balloon appears to be better than cap-assisted for cecal intubation rates. So, in summary, an approach to safe and successful colonoscopy: first, you want to customize your prep for the patient at hand, use appropriate sedation, of course, and then expert technique, as I described. And then it's important to classify the anatomic problem and choose the right instrument. You have to anticipate sigmoid anatomy, change instruments in the difficult sigmoid, master the left colon, especially with regard to looping, change solutions quickly. And when I say change solutions quickly, when I'm with a fellow, you'll see them doing the same thing 3, 4, 5, 6 times. And I always say, you can try the same thing once or twice, but if that's not working, go to something else, whether it's pressure, position change, or a different scope. And then, of course, be willing to quit because ultimately you don't want to cause a complication. And then for the difficult colonoscopy, you've got an array of options from overtubes, narrow diameter scopes, balloon-assisted colonoscopy, water exchange, and even magnetic imaging, which I didn't have a chance to show you, but can be effective. And then when it comes to incomplete colonoscopy, remember that if you have a low-risk patient, you could certainly do CT colonography. For high-risk patients, you want to either repeat the colonoscopy or go to balloon-assisted colonoscopy. And I think overall, it's better to try colonoscopy again rather than doing radiology, because studies have shown that doing X-rays are less sensitive than going to colonoscopy. And then, although I didn't talk about it, and we don't use it much in the United States, another option could be the colon capsule. So with that, I will conclude. Thank you all very much. Thank you.